Good morning.
Good morning.
Hi everyone, I'm Dr. Kate Nolt from the Masters in Public Health program at the Graduate School at Creighton University. Welcome to my conversation with Dr. Caron Gray. Dr. Gray is an OBGYN, and she's going to talk to us today, with me today, about maternal and child health as part of National Public Health Week, which is April 6th through the 12th. And so you're viewing this probably on Tuesday, which is Maternal and Child Health Day of that week. So welcome, Dr. Gray. Thank you.
Thank you for inviting me. I appreciate it.
You're welcome. I'm thrilled. I'm thrilled. So just in full transparency to anyone viewing, Dr. Gray and I work together as part of a research team. We've done a couple of projects together. So Caron and I are also, we socialize, and it's such an honor and a pleasure for me to have been able to get to know Caron over the last few years. I'm just always thrilled when I can spend time with her. So Caron, thank you so much, because I know how crazy busy you are.
Oh, my pleasure. And likewise, Kate, likewise.
Thank you.
Thank you.
So I just want to make sure that everyone watching knows what you do and who you are. And so can you give us a little bit of your bio, I guess? So who are you? Where are you? What do you do for Creighton and for your work?
Very good. Very good. So briefly, as you mentioned, I am a general OBGYN at Creighton University. I've been at Creighton since Creighton University CHI Health. I've been there since 1999, so now 21 years.
Nice.
Prior to that, very quickly, I'm originally from Illinois, went to medical school at Northwestern in Chicago, and then the military paid for that, and so I went into the military for my residency in Northern California, and then here we are. I have had a broad range of interests through my career, and I have been practicing in the academic setting since 1999, and prior to that in the military. So
what kind of courses do you teach?
I am teaching the residents as learners as well as the medical students, and basically I am involved with a lot of just the basic core for the medical students, mainly in the third year. In the second year, we do teach some reproductive endocrinology. And then I have a special interest in global health, as well as in vulnerable populations. I work with the residents down in our federally qualified clinic called One World Community Health Center in South Omaha, and also at the VA, at the Veterans Hospital for our women.
I didn't know you were working in VA. Yeah.
Yep, for our women vets. So I do have particular interest in vulnerable populations. And maternal child health, you hit two vulnerable populations that can really make or break society's well-being. So
you and I got involved together down in the global piece, right? So there's maternal and child health issues globally that are very similar, right, to the ones we have here, but then there's distinct differences, and hopefully we'll be able to distinguish and discern some of that in the conversation. I had no idea you had a military background.
I do, in the Air Force.
Nice.
Yep.
Okay, something else for us to explore together.
Yes, exactly.
I appreciate that, and I'm so grateful for you to be here. So one of the things that we want to try to get out of today is talking about maternal child health, both, like we said, domestically and how it may differ or not in other parts of the world. You and I have worked together in the Dominican Republic with very vulnerable populations there. But not under maternal and child health, but we certainly see some public health issues there. So what in your view is the definition of maternal and child health? How would you start the conversation of what maternal and child health actually is?
So it encompasses the points of many things, actually. And many people think it is just purely centered around pregnancy and immediately postpartum and in the neonatal period, up to 30 days. But indeed, it actually scopes really the reproductive age women, including down into our adolescents and up into our women in their 40s. And then what happens with the children of these women if the women are not kept healthy and in social situations that help them provide for their children and keep them and their children safe. So essentially, what maternal and child health is focusing on is really trying to decrease the preventable and actually try to end the preventable deaths that are seen mainly in, maternity care, but also in the neonates as well. So maternal mortality rates, we're focusing on indeed, and then basically as far as complications that have to do with pregnancy, which could lead to preterm delivery, which then leads to our infant and neonatal mortalities.
Maternal, let's start with maternal, right? So yes. What contributes to maternal mortality?
So I'm glad you asked that question, and I'm going to take this opportunity to just kind of mention how the World Health Organization had made it one of their sustainable goals and of trying to continue to decrease. And back in 2000, it was one of their goals to try to decrease the global maternal mortality rate by, I believe, 70%.
Ooh. And do you know how they're doing now that we're 20 years later?
They did very, very well in many, many, many countries. So I am thrilled to say that the world responded and really decreased their maternal mortality rates. And those actual percentages are available on the WHO website. Okay. But what I'm sad to say is for us in the United States, while the world was decreasing their rates, we essentially increased our rates. So the WHO organization does say that from 1990 to 2015, actually there was a decrease of 44% of maternal mortality in the global world. And the US, unfortunately, went up to approximately 17.2 in, and that's out of 100,000 live births.
So let me just clarify. It went up to from, it went up 17% or it went up to 17% from a lower percent?
Actually, it went up to 17.2
per 100,000.
Per 100,000, and it was down. If I can pull up one of my charts, it was down much. I have to find that chart, but let's just say that it has increased dramatically over those 10 years to a high in 2014, and now it is, which was 17.2. And this has been a huge deal when it comes to what the United States has been trying to begin doing to address this problem. And basically, if I can say that the main causes of maternal mortality, at least in the United States. So what we can do is we can address it both from a United States perspective, and then we can address it from a global perspective. So let me get those numbers for you again. So from the CDC, basically the US maternal mortality rate doubled from 10.3 per 100,000 live births in 1991. And I apologize for my my data. It was 23.8 in 2014. And
Wow.
essentially, we say that 2/3 of those deaths are preventable. And so while—
And these are just maternal.
maternal,
correct?
maternal.
Maternal.
We're speaking maternal, and maternal mortality is probably what I'm going to focus on more here. I am on if you want to bring it down to a microcosm or into a community level, I am on a fetal and infant mortality review committee for Douglas County here in Nebraska.
Yes.
And we focus on infant and neonatal deaths and what could possibly, from a public, it's very much a public health perspective, and what things we could potentially recommend to the health providers and to the community organizations in helping to prevent those deaths. And so from the infant point of view, we can touch on that a little bit later.
Yeah.
From the mortality, from the maternal mortality,
the causes.
The causes, what we're seeing now in the United States is cardiovascular conditions. So those are increasing, and we're talking about all different cardiovascular conditions, meaning hypertensive diseases of pregnancy, such as preeclampsia, cardiomyopathies, which is this dilating and dysfunction of the heart after delivery. Strokes is another cause of death in these women. And then the second leading cause in the United States is infection, which is about 12%. And those infections are usually immediately postpartum and can lead to sepsis, and if not treated aggressively, can lead to mortality. And then—
Is that preventable? Or are these infections that are—
these are preventable
infections or hygiene infections, or—
Well, we'll tell you what, I'll tell you there's a lot of different components to that.
Yeah.
We follow very strict infection control measures, but I will say that basically the patient has changed a bit over the last 20, 30 years, and I will touch on that.
Okay.
The third leading cause in the United States is hemorrhage. And in the world, globally, hemorrhage by far and away, and hypertensive diseases and infection are what takes maternal lives, and sometimes with the infant or the baby, the fetus, with her. So what has changed dramatically, and what we have identified in our community review as far as the fetal and infant mortality goes, is our population is increasingly obese. And with obesity, we have, and we're just not talking about BMIs around 30, we're talking about more of the BMIs that are greater than 40, which is morbid obesity, and even the BMIs that are greater than 50. But
so then the hypertension and the cardiovascular disease is comorbid with that?
Yes.
Is what you're saying?
That's comorbid, but also infection rate. So if we do a cesarean section on somebody with a BMI, certainly greater than 35, but even greater than 30, that increases their risk of having a wound infection, along with their comorbidities. If they have hypertension and let's say diabetes or gestational diabetes, their sugars are going to have to stay in control in order to help with the healing of that wound. So infectious risks go up with our obese patients and their comorbidities. So we really believe that from a public health perspective,
please,
what is preventable? What can we focus on? Obviously, preconception education is key, and we always come back to that. But unfortunately, access to preconception education, many patients don't plan pregnancies. 50% of all pregnancies are unplanned, unintended. So when you have that kind of rate, it's very difficult to make a difference unless on your yearly visits with folks, if they can have access to well woman care, access to free or low cost contraception, and it really should be free or very low cost so that it's accessible, are big keys. And then of course the patient's taking advantage of or partaking in the contraceptive services. So having a healthy—
So if they're not, but let me just, excuse my interruption. So if they're,
Please.
so if there's planning going on, when would a woman ideally be saying, does a patient come in and say, by the way, doc, I'm getting ready to plan on having a baby in the next year? Or is it part of your questioning of a person in a certain age range where you say, are you guys planning to have any children? Because if you are, now would be a good time to start talking about, and wait a year before you do it, that kind of thing. So how does that happen at the patient level, bedside kind of table side?
Absolutely. Excellent points. So if we could get our women to come in on a yearly well woman visit, that's at every well woman visit, that should occur. And we talk about being on from a public health perspective, one intervention that has helped tremendously for many years now is having them on folic acid or just a regular multivitamin. You only need 400 micrograms of folic acid to decrease neurotube defects.
And that's even if they're not pregnant?
Even if they're not pregnant. So I try to put every reproductive age female, make sure they're on some sort of multivitamin. And that way, if one of those unintended pregnancies comes along, we're already ahead of the game. The other piece is working with our patients and letting them know, and I like to discuss it by saying the words BMI and not obesity, because it brings a different connotation. So helping them realize that if they're not at a BMI less than 30, what kind of increased risk that it leads to with their pregnancies. So what we're seeing, Kate, as far as that obesity goes, increased risks of the preeclampsia and the hypertensive diseases. And then some of those lead to indicated preterm deliveries because the disease has progressed to with severe features or to a severe rate that we have to deliver the baby in order to help the mom become well, and baby could die in utero.
So is there a mechanism in place, do you think, and if not, should there be one? You were saying preconception education would help prevent a lot of this. So are there programs, or does public health need to do a better job of creating these programs or putting them out there, where you might say to someone of reproductive age, hey, if you're even thinking about this, can you please go to this place or go to this, take this class, or, is that in place at community levels, do you think, or
so
could we do a better job?
That's the key. And I think it varies from community to community. When I came on this review committee in Douglas County, I was so impressed with what the community and the public health folks have done at the community level, trying to get all these moms educated. Then it becomes a factor of trust and a factor of culture and health standpoint. How do you reach people and have them trust your message and listen to your message? So what kind of branched out of this in a microcosm here was with CHI Health. One of our hospitals is up in North Omaha, which is more of a predominantly African-American community. And we got together with the North Omaha community. It was a committee, and we had community leaders, all the things, all the correct public health stuff. I was so impressed.
Yeah.
And it came down to, do we need to go out to the churches? Identifying community leaders that would take this on and go around to the churches kind of as a road show, as it were. Having patients take advantage of the services, and that, again, we find probably has to do with social determinants of health. And
what about the refugee community? I know Omaha has a very, and so do, and Philadelphia does too. What about the refugee community, where you have so many different faith-based things going on, culturally based practices, and is there efforts to do the same thing in those communities?
So what is interesting there is that they do have access to health care, and there is a lot of attention to the refugee communities when they first arrive. And so I think, however, because there's so many things going on, helping them get stable housing, helping them get employment, helping them understand what it's like to live in the United States, we end up with possibly protection from pregnancy not being on the top of their list. Culturally speaking, our patients from some of our East African countries, and the Sudanese, Somali, and many of our patients from our Muslim faith, having many children is very, 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 very important to their faith. And so they will, that cultural aspect, no matter how strong of a relationship you make, there's some things you just can't change and can't do anything about, and that's where you kind of have to accept that piece and do what you can.
Yeah, that's where the preconception education, I think, is probably circling back to that. You can just help inform maybe in a way that's appropriate for their culture, I guess, because we're sort of you're transitioning to my next question pretty easily, which is, you would think we would have pre-planned that, but we didn't. Because we work together in the Dominican Republic, where we see a lot of, because this circles back to the global picture of how things are going well globally and less so in the US in terms of comparing the two, where we started at the WHO efforts. And when we're in the Dominican Republic and working together, we do see some of what you're talking about there as well, that culturally having children and, is part of the belief system, and and we have to sort of address that and some of the other comorbid issues that happen before conception or that exist. And so what is happening globally then that may not be happening, or could be happening but could be better here in the United States, to reduce those numbers so much?
Exactly. So I think the elephant in the room that we have to bring up and continue to address is where women and children fall as far as importance and respect, and really the importance of women and children in a society.
So if it's a paternal society, you mean, versus?
Yes, in the paternalistic, we have essentially pretty much still a paternalistic world. And even here in the United States, though we would like to think that women and children are put front and foremost, it's still, you see every day where because of, without getting political or without
Right.
getting opinions there, we still have a long ways to go to truly elevate
Yeah.
women and children to where we are saying they should be. Same thing in the global aspect.
So you're talking about equality then,
Equality. Thank
in
you. Gender equality.
equality and social justice in terms of treatment of each other.
Exactly. And you
Okay.
can speak to that probably much, much greater than myself, but that's something that I see. I mean, to the point where it doesn't seem like you should, in our country, that contraception should be a right. People don't understand how pregnancy and contraception are so entwined with a woman's health. And I mean, Healthy People 2020, our own Institute of Medicine said, Healthy People 2020, we want to make sure that our women have access to contraception and that the pregnancies are planned, because we see that we can make a difference in our morbidities and our mortalities.
And I want to qualify the comments that you're making to say that this is not a political statement, and that your perspective is one of, as a doctor, seeing all of this and removing any kind of, religion or belief system or political from the conversation, because you're in the kind of front lines of what's happening and the long-term results of what happens to a mother who doesn't have access to care or doesn't have access to education to help themselves and their children. And so it really benefits, I think, children in the end to have all of these things available to a mother, because then you have a better situation for a child for their healthy development, not just the birth part, but postpartum as well. I guess breastfeeding is still something. Are we still like what? I mean, I know from a public health perspective what we're saying and what we do, but how much do you actually see that young women today are breastfeeding and understand the value to a child of that?
We're making progress there, and it's very, very exciting to see. And I really believe that if there was something that the Affordable Care Act, said we're going to pay for breast pumps, we're going to try to get into some of these businesses and say, this is important for women to be able to have a break to pump, because the breast milk is the healthiest thing for their babies, while again balancing the autonomy of the mother. If it doesn't work out for the mother, if something's going on, obviously we want to be supportive of the mother totally. But we're seeing progress, and our lactation consultants and education in the prenatal period, and I think also community education has gotten out there, and that has been a real win, I believe. And one of our perinatal quality indicators that I believe the perinatal quality indicators come out from the Joint Commission, which is that institute that kind of monitors the quality of our hospitals. And we have improved tremendously in our exclusively breastfeeding moms. And we saw that change really over the last 10 years.
So there is some bright spot in these numbers, because when we started with the maternal mortality rate not being where it needs to be, it's kind of awful to see that what we have available to us, both in medicine and in public health, that we can't seem to improve those numbers. So that's a challenge for us, and we need to pick up the baton on that challenge. But the other side of it is that breastfeeding is it on the rise, or like over time you've seen it be more to young? And we haven't talked a lot about teen mothers or younger mothers, even if they're not teenagers, even in their early 20s, breastfeeding and taking care of themselves and their children as well, because being young in and of itself today is just so difficult.
Yes.
Especially these days with the COVID-19 thing going on. So we need to make sure we include that too, communicable disease and all that. So let's start with so we're talking about the breastfeeding as being a bright spot. How are younger mothers doing with that as opposed to a little bit older?
I think that we do have challenges in the younger mothers, especially if they're still in school. So although, again, the schools have come along and have supported having them pump and doing everything they can to keep breastfeeding going. One population that that I take care of that I'm sad to say is our undocumented immigrants, our undocumented patients who work in situations where they literally they are afraid to lose their jobs. They don't have a lot of rights per se. They are not even starting to breastfeed because their families need for them to go back to work within 2 weeks. They don't have time to pump. They don't want to have the issue with engorgement and things like that. So that is the population that we have yet to hone in on to try to help improve those numbers. But overall, I think on breastfeeding, it's done well. And the younger patients, it's going to be just continued education. But if
now, do your residents, do you guys? And I don't know how this works really. I kind of do, but not. You can talk about this a little bit. How about the WIC program? How does the referral to the WIC, and would that be helpful in this formula of trying to improve things? And who can go there versus who can't, or who shouldn't, or what is that? What happens with WIC?
Oh, absolutely.
WIC is the women and
infants and children
food, kind of a food program, but I know they also do more than just that.
Oh yeah. Food and nutrition. And I can really give praise to the WIC folks down that work with the One World Community Health Center and up at Charles Drew too. I think the qualified,
and I can do the same here in Philadelphia. They're very good.
The federally qualified health centers really are doing it right. And if some of our more private sector clinics could have those automatic referrals in place, we could do so much better. But our patients certainly have automatic referrals. Once they come into the system, they're automatically referred to WIC. And if they don't go, we keep asking them to go. And WIC works with us and tells us what we need to do.
But an undocumented patient,
they can go.
They can go too. Okay, that's good. So that's a boon for public health too. I mean,
that's
good for them.
Once the baby's born, the baby is a U.S. citizen, and WIC provides services for that U.S. citizen.
Okay.
So then through that, the mom can benefit from education and things like that while the baby and the child is getting the services.
More good news, hopefully.
That is great news. Great news. Something else I want to, something else I want to say that has been great news from a systems change, and I believe public health certainly falls right along with wanting to have system answers, right?
Correct.
And systems changes. So the hemorrhage issue, and we have just made leaps and bounds. And the California Committee on Maternal Morbidity and Mortality and Hemorrhage, they put together an excellent protocol. And also we have now triage patients. So we find that if we're not prepared for the hemorrhage, obviously patients bleed more, require more blood products, and are at increased risk for morbidity or mortality. So preparation is the key. And so we've, of course, identified all of these different things that increase somebody's risk for having a postpartum hemorrhage. So the woman hits the floor. Right away, the nurse looks at all this triage, identifies whether she's at low, moderate, or high risk with her risk factors. And then if she is at high risk, she talks with the doctor, and we as a team decide what we're going to do to prepare for that. And for example, we have 2 IVs in, one IV, large gauge IVs. We make sure we have blood in the blood bank that is typed for her. We have the hemorrhage cart, we call it. So one of the things that came out of this was the hemorrhage cart, and it sits outside the room. So that model, as you know, is essentially a public health or systems-based model that has done
prevention. So, but how do you have that conversation with a person? Because are there circumstances where the hemorrhaging is sort of, if someone's 35% or over 30% BMI, you know, is it a certainty that they would hemorrhage, or, you know, likely higher risk?
That's just one of the risk factors.
Yeah.
So you put that into play. For example, the different things that put you at increased risk.
Yeah.
Obviously history of hemorrhage, obesity, but other things that are happening while, if you think you have if there's a big baby in there, anything that over distends the uterus. If they've been on oxytocin for a long time, then while they're in the labor and delivery ward, we may increase their risk level higher, and then change what we're doing. Different medications, like if they're on magnesium, let's say, for their severe or for their preeclampsia with severe features, magnesium makes the uterus not contract. So it's a fluid thing, and we talk to the patient about what we're doing to try to prevent this hemorrhage.
So while we're talking about risks, and we're kind of getting close to the end of our time together, so I have 2 things I want to ask you, but we were just talking about risks, which sort of leads me into asking you about maternal and child health and exposure to things like COVID-19 and communicable diseases, and, you know, balancing being pregnant and needing to be out for things versus not, or in a planning phase of being pregnant, taking that fully, prepping our bodies. And so can you just talk about risk exposure to different things and maternal health and, of course, child health as a result of that?
Very good. Absolutely.
And by the way, drugs involved in that too, like what they're risking when they ingest, you know, medication or drugs, alcohol, smoking, that kind of stuff. But that's also risky, but also in the communicable sense, that's non-communicable, but in the communicable sense, since we've got COVID-19 kind of hot on the plate right now.
Very good. Very good. And I know we don't have a lot of time. I'm going to talk about this, but then I do want to end just with the massive disparities within our country. And again, drive home.
That's sort of where I was going to go after the communicable.
After this, perfect.
You leapt ahead, Caron.
Okay, I just wanted, because that is.
No, that's okay. Believe me, I kind of I got it. But I'd love to make sure that we include talking about
COVID
exposure and risk and environmental things going on that are like, do we need to be paying attention to that? Because I know in a state of pregnancy, you know, women are very happy, you know, I'm happy, I feel good, I'm in my my second trimester, and yay, I made it. And so it's a happy time. And so you kind of might not pay attention to some of the things that are going on that we need to be paying attention to, such as social distancing currently. So help.
You betcha. Oh, and I wanted to note that it's called the California Maternal Quality Care Collaborative.
Thank you.
California Maternal Quality Care Collaborative. It was excellent.
Thank you.
So luckily, I mean, just like everyone else, we don't know a lot about what COVID-19 and pregnancy, but what we know so far is it appears that pregnant women are not we're putting them into the category of being at increased risk of possibly getting the infection only because pregnancy is a slightly immune compromised state where the immune system does get pushed down a little bit. However, in the science so far and what we've seen in Italy and China, we are not seeing pregnant women coming in any more ill on ventilators any more often than non-pregnant. Now, we may just not have enough numbers yet.
Right.
We know for a fact in flu and influenza, which I'm not comparing COVID with influenza, I'm just going to a different infectious disease. With influenza, we do know that a pregnant woman is 6 times higher chance of dying, increased risk of being in the ICU on a ventilator, and having respiratory, more severe respiratory morbidities than a non-pregnant woman. And that's why we push the influenza vaccine. So
before pregnancy, like before they pregnant or during pregnancy, they
during,
get the vaccine?
oh yeah, that's a safe vaccine. We encourage all of our patients to be vaccinated. First, second, third trimester, doesn't matter. There's no issues with congenital anomalies or teratogenic changes. So far with COVID, we're going to contrast it to Zika. We have not found anything so far, again, only so far.
Right.
Any congenital anomalies or teratogenic nature of the infection with COVID. Breastfeeding with COVID, right now it's all about transmission. So it's, the caution is if that woman is positive, she's going to need to do everything in her power to not transmit to the baby. And sometimes with breastfeeding, you know, you got to wash your hands, you got to wear your mask, you got to make sure. You may even end up pumping and having someone else feed your baby. These are the kind of things that you would do to put into place, but it's not.
How about in utero? Are there any risks in terms of transmission through placental or, you know?
So far, we don't see any cases of what we call vertical transmission in utero transmission. So far, that's some of the good news, I guess. But we still are cautioning that a pregnant woman would still be in the category of someone who could get possibly more ill than a non-pregnant woman just because of the immune system.
Right.
But we don't have enough cases yet to say one way or another. But what we've seen so far, we've not seen them with the virulent respiratory issues.
So are the precautions that they would be advised to take any different than the normal population? Like a lot of people want to wear masks and, you know, but really should pregnant women be doing something differently that were more to protect than what the population is being asked to do?
At this point in time, no, just with the caveat, we don't know enough yet, but from what we know, they should just be taking the same precautions.
Social distancing, isolation, within reason, calling your doctor if there's a problem, that kind of thing. Okay. Yes. And I guess the same thing would apply to other communicable situations, understanding what precautions need to be taken to avoid contracting.
Influenza is our other communicable disease as far as aerosol types spread. Obviously, immunizations prior to pregnancy are very important, just the usual childhood immunizations. Let's see, as far as, you could go through another whole podcast on STD
some of that.
and all that.
So should women be, so a lot of the way to address COVID-19 is like addressing the symptoms. So should they automatically be taking Tylenol or ibuprofen or self-medicating like that? Or the first line of thing is call your doc and let.
Well, I think if you feel those screening questions, fever, cough, shortness of breath, sore throat, if any of those come up, call your doctor.
Yeah.
We may have them take some Tylenol and see what their symptoms do, or we may have them come in and be tested. It's
Okay.
kind of our triage that we're
Okay.
going through, just like anyone else. But obviously, we'll probably be a little bit more conscientious with our pregnant patients, since there's two, and since there's the other patient as well.
So let's talk really quickly about the non-communicable things that can come up that a woman should be cognizant of, like smoking. A lot of people I know from my work in the cannabis and alcohol, tobacco, and other drug area of public health, I know that lines at cannabis dispensaries have been wrapped around, and there's a lot of people are buying, and some people believe that for the nausea that taking, smoking cannabis or vaping THC or something helps with that. Alcohol consumption, how would you, and those are non-communicable kind of behavioral things. What would you say in terms of maternal and child health and what it does to the fetus and after, about those non-communicable kinds of things?
Sure. So basically, we recommend 0 amount of any of those things in pregnancy. Smoking tobacco or tobacco products and alcohol has been around for a long time. And we do know that smoking can increase the risk about everything in pregnancy, from just having the baby not grow so well or growth restriction, to just problems with the placenta, abruption, where the patient bleeds and has trouble there, amongst other things.
Right.
Alcohol, the fetal alcohol spectrum of what different things can happen with that. And those babies usually have some sort of effect mentally and in their functioning there. And of course, we want 0 amount of alcohol once you find out you're pregnant. If you have some alcohol in the first trimester before you find out you're pregnant, it's very unlikely that that's going to affect your baby long term. They talk about having just no alcohol is acceptable once you become pregnant. So marijuana. So our college, American College of OBGYN, has put out community opinions and guidance about marijuana. And the bottom line is we actually don't know. And the fact that more and more women are smoking during pregnancy because they think it's safe, that it's not tobacco, we don't know. We don't know what may happen to the baby's neurologic system. We don't know if it can actually cause issues with growth. And we're going to learn more and more now that more and more patients are partaking in marijuana. And the edibles, we don't know. Obviously, smoking is smoking.
Right. That still does damage to the lungs, and it still can cause, I would assume, a risk of asthma maybe to a baby. I don't know.
No, it won't cause any issues to the baby's lungs. It will just be the mom's lungs.
Right.
It would be something to do.
Of course, vaping is having all of the acute lung injury related to vaping, whether it's nicotine or THC. Just vaping as a mechanism is causing a lot of damage to the lungs. And that's already tested, and we already know that that's out there as a public health issue and a health issue in medicine as well. So is that part of your intake too when you talk?
We always ask. Yep, we ask about any use of any of those products and try to educate the patient. We understand that addiction is a very, very, very tough thing. And so what we found in some changes, especially with addiction medicine, is that if you're pregnant, it moves you up on the list. If you need to go into a rehabilitation center, get you into a rehabilitation bed, possibly mental health issues as well. And so we really, really enforce the fact that we're there for the mom, because if we can get her healthy, baby will be healthy. And
well, I know that addiction to drugs can affect the baby. In terms of what you're ingesting, nicotine.
Well, the different neurologic and different.
Right. Well, you have babies born as addicts themselves. right?
Right. That's with
So
the
the
opioid
opioid,
crisis.
yeah.
Which
So
again,
this, yeah, this circles us all the way back to your very early comments about planning, right? And preconception education to make sure that a woman is ready, both physically and mentally, to be pregnant and to be willing to give up some of what they do on a daily basis that could harm them, but then by extension harm their child, and then they're not available as a healthy mom to
and
raise that child, right? I
well,
guess.
and I want to put a plug right now in for the significant others and the fathers, the husbands
Mm-hmm.
of these women. It's incredibly important if we can help them and support them and educate them the
Mm-hmm.
importance of their role in this whole situation,
Yes.
as
I'm
opposed
so
to
glad you said that, because I was
by
walking
themselves.
just the other day in my neighborhood, and there was a parent with a like 2-year-old or 3-year-old tiling up the sidewalk smoking, like, and the smoke was going right back to so the secondhand. I was like, I couldn't believe it, that it's, and I mean, I would
Educate.
like to think we're all pretty, at least basically educated that that's not a good thing. But it still does happen. So I love that you talked about the father and the significant partner.
Yeah, the partner and the father of the baby is so important.
Mm-hmm. Fantastic. So you may have already really touched on this, but I'd love to end on, if you could change one thing about the state of affairs in maternal and child health, what would you change, and why that, versus what would be your like song, your swan song on
My
on
swan
the
song,
conversation about what this is what we really need to do.
the massive disparities in our country.
Okay.
We have the lowest, in Nebraska, we're very fortunate, for example, to have a very low perinatal mortality and morbidity. However, our African American population is 3 to 4 times more likely to die in childbirth than white women, and that's in the entire country. And this is regardless of education, income, or other socioeconomic factors.
Wow.
So
And Hispanic
we
women, do
are
you know as much
behind.
for Hispanic women?
Hispanic is not as much, but our Native American population is as well. So we
Okay.
talk about in the United States, we have, as I mentioned, that 23.8 in 2014, and I think now we're down to 17.2 per 100,000 live births, which puts us down at like 49 in developed countries in the
Wow.
in the globe. We are,
Incredible.
and this, according to the World Health Organization, and I come back to Black mothers, it says Black mothers in the US die at the same rate as pregnant women in Mexico or Uzbekistan. And it needs
Wow.
to really open our eyes
Mm-hmm.
to the disparities. So we have double the rate of maternal mortality in Black women. Black women have 42.8 per 100,000 live births. American Indian, Alaskan Native, 32.5 per 100,000 live
And
births.
is this the state of affairs also for infant mortality, which we didn't really touch on much, but is it the similar for infant mortality, that they're higher in these populations regardless
Yes,
of
you can
education?
extrapolate. You can extrapolate to that, because many times we're having indicated preterm deliveries or preterm deliveries, and we feel, I mean, we're still trying to study it and figure it out, but it's likely that just the overall social stress of being a person of color in this country,
Mm-hmm.
regardless of your socioeconomic status, education, or income, is playing some part
Mm-hmm.
in what happens with morbidity and mortality. So it's frustrating, but I think that if we could do something, I would love to have at least decrease by 50% that disparity. And I think a lot of what we're seeing are the cardiovascular and hypertensive
Yeah, the numbers are similar. Yes. In those populations, there's, yeah.
Indeed.
And so again, I think, do you believe that where we started at this preconception education within these populations, is there a role for, like in the Dominican Republic, when we work with the communities we work with, there are health promoters directly in the communities that tend to do this type of education. And yes, we're working on improving that, the functionality of these health promoters and their role in educating. Do you believe that the communities here in the United States would benefit? Some of them have health promoters and some don't. Yeah. And so would that be a model that you would think would be a good approach to this issue? Or what have you thought about?
We've got to figure out what influences our African-American population. I don't know we have to find the folks that they trust and believe, and then be able to bring them in and receive the care. Because at least in my own personal experience, these patients at least have access through their insurance or Medicaid, but for some reason, so is it the other socioeconomic or other social determinants of health, right? Is it do they have unstable housing? Is it a situation where they don't have any choices and they can't, it's their other children's care? There's
and also, I mean, right, access to food and living conditions that are, you know, those are all stressors against, you know, yeah. So these are the biggest challenges that we're facing. And so that's the state of affairs you want to address the most. So let's end on, and we've talked along the way about some successes. We didn't say much about infant mortality separate from maternal mortality, but what are some successes in terms of maternal and child health overall?
Absolutely. Well, I think certainly globally, the decrease in mortality, and I think those frankly came from a real focused effort of getting a trained personnel at the delivery. So making sure that those women are at a place where there's trained personnel, whether that's a midwife or medical provider, and then very creative ways to address hemorrhage early, have done tremendous help in decreasing the maternal mortality rate, in therefore translating a bit into infant mortality as well, and neonatal mortality. In the United States, like I said, we have work to do since we had a rise up till 2014. It's starting to go back down again.
Okay, so that's a good sign.
So that's a good sign, but it's only been a few years that the data has been recorded. So, but it is, I think we have up to 2000. I mean, we have it up higher, but
to 18, I think, is it?
I think to 18. But I think just like all healthcare in the United States, we're spending a lot of money, but we're not seeing outcomes. So we're doing public health is the answer, and education is the answer. And I wish I knew the silver bullet, but
I join you in that.
But I think we really have to do like we did in our research project in the DR. We have to do our community needs assessment. We have to do our focus groups. We have to get down into the down and dirty and get the answers from the communities themselves.
And maybe around what their belief system that they're building their approach to their health around.
Absolutely.
Well, Caron, I have to tell you, this has been amazing talking to you. And you and I have never really gotten into the weeds of my career more in public health, I think, than we have with you. So it's been a double pleasure for me to learn more about that and about your career and what you've brought to the table. So it's been amazing. And I really appreciate everything that you shared, both personally and professionally, for National Public Health Week, Maternal and Child Health Day. And we're going to be sharing the link to this interview with as many people as we can, so that all of what you've guided us through, can maybe lead to some efforts. So thank you. I really appreciate it.
Thank you, Kate, and
You're
stay
welcome.
well.
Thank you.